Okay, well, thank you very much for lasting to the end of the 10th Love Your Bones conference. We're very grateful that you've come. We had a whole series of questions that were sent to us, and I've looked through them, and some of them have sort of been answered already. There'll be as much opportunity as possible for people to ask their questions to the floor, and if you want to afterwards, you can hang around and talk to me directly. Let's just give you a quick update about medication and then plunge into a few questions. So the standard treatment, medication-wise, is calcium vitamin D with alendronic acid. So if alendronic acid doesn't suit you for any particular reason, then there are other forms of oral bisphosphonate, risedronate, ibandronate. And then if those standard treatments are not suiting you, then there are other things that we can use on the right-hand side. Okay, there's an injection that you can have once every 6 months. There's an intravenous infusion that you can have once a year. There's also a tablet that you can take every day called raloxifene. And there's also strontium, but strontium's sort of fallen from favour these days. So are there any new treatments on the horizon? So I know that Mark Edwards talked about some new treatments, and so I'm only going to really talk about these briefly. They're all heavily steeped in bone biology, okay? And rather than give you a biology lesson, I just thought I'd put a picture up, okay? There's all this stuff about osteoporosis or rank ligand and Wnt signaling and sclerostin and cathepsin, but it's a bit late in the day for that, we'll move on. So there is this thing called odanacatab, okay, which is a cathepsin K inhibitor. Now, a cathepsin K inhibitor is the enzyme that the osteoclasts, the cells that break down bone, actually use to break down and digest bone. Now, the idea is you inhibit that enzyme, then you can reduce your risk of breaking a bone. And so it's been a while. They said that it was going to happen and be available last year. And it's only, it still hasn't appeared. But it did show some beneficial effects. So within 6 months, there was a 54% reduction of vertebral fractures as shown by the x-rays. In terms of actual people complaining of back pain and then being shown to have vertebral fractures, there was a 72% improvement at 3 months. Okay, so it does seem to work, and it does seem to work well. The only sort of concern has been there was a small increase in stroke. Okay, so it's not looking too great, okay, and it hasn't yet been released, but we'll see what happens. They still haven't quite decided, but it's something that, osteoporosis by and large is a condition that shouldn't, shorten one's duration on Earth. And so really having side effects that might do that is a pretty bad thing. So we'll just have to watch, see what happens. But I'm not in a rush to recommend it. There's another drug called abaloparatide, which is in fact very similar to teriparatide. I don't know if people here have had teriparatide, but it is, actually I didn't put it up. I should have put it there. It is one of the available ones. Teriparatide should have been on the right side. It's an analogue of parathyroid hormone, which is something that our body produces anyway. Okay, so it's simply boosting a hormone that our own body produces. Okay, and in fact that has shown some pretty successful results. Now, abaloparatide is using the same target as teriparatide, this one that is available already. So why should anyone prescribe the new one when they can prescribe the old one? So they had to show that their treatment was better than the old one. And in fact it was. So you can see on the left-hand side you've got placebo. In the middle you've got teriparatide, which is the one that you can get nowadays. And on the right-hand side you've got abaloparatide. And in fact, at least for major osteoporotic fractures, there was an improvement over and above the active drug, teriparatide. Now, the reason why this is actually sort of unusual is that most people do not test an active drug against another active drug. Most people do trials against placebo, sugar tablets, okay? Because it's much harder to show benefit against another active drug. And so when you're doing a trial, you've got to get a much bigger and more expensive trial. But anyway, so this one is showing a little bit of benefit, and the reason why they had to compare it against an active drug was because why should anyone prescribe their drug? Okay? So it does seem to be of similar, if not better, safety than the existing drug. With teriparatide, which is a drug that we use, it's interesting because it tends to boost bone, but we haven't used it that much because in very high doses in mice, after 2 years of treatment, people get sort of small tumours on their bones, or mice do anyway. So in humans, we're not allowed to use them for more than 2 years. But anyway, so that's one of the other drugs. Now, another drug called romosozumab. Romosozumab is an interesting drug. It's the first of a group of drugs called a sclerostin inhibitor. Now, the actual effect in terms of improving bone is really quite dramatic. I mean, I don't know if you can tell, but on this graph here, you can see that 2 years of romosozumab increases your bone density by 16%. Okay, so that's really quite a lot. Okay, and so it is quite interesting. In this trial, they gave romosozumab for 2 years, and then they gave denosumab after that, and you can see that with denosumab following it, it can go up to 20%. So that's really quite an amazing improvement, but we just have to make sure that it's a safe drug and an appropriate one. So we still need to wait for that data to come. And as someone, I think someone asked, I overheard someone ask Mark Edwards, because I think Mark talked about romosozumab this morning. Someone asked him, is it NICE approved? Well, no, it hasn't got a license yet, but even when they do release it, it'll take time to get approved by NICE. So it's just nice to know that these things are happening. So anyway, so let's plunge into your questions. So that we had a whole series of questions. One person said, I was recently diagnosed with osteoporosis at the age of 50. Why wasn't I given any medication? Okay. Now, osteoporosis is really a label applied to someone who's got low bone density, okay? But bone density is only one of the risk factors, okay? It's only one of the components of why people fracture. And really, age is another component, okay? Now, younger people tend not to fall and tend not to fracture as much as older people. So you can see that for a young person and an old person, if they both have the same bone density, they both have osteoporosis, you're less inclined to treat a younger person. Does that make sense? And in fact, this is the definition of osteoporosis at different ages. So each of these is a population curve, okay? We're all described by these sorts of bell-shaped curve. You take anything, you take height, you take weight, you take blood pressure, it's all described in a population curve. So you can see that at the age of 25, the number of women in green with osteoporosis is very, very small. Can you see that? But you can see there's still quite a lot of light blue, which is osteopenia. Okay? So by definition, large proportions of young people are osteopenic. Does that make sense? Even at the age of 25. And there was one question that said, I'm osteopenic, how do I make sure that I don't get worse? Okay? Now the thing to remember is that osteopenia is not such a terrible thing. Okay? In fact, it's very common. Okay? And just because you've got osteopenia doesn't necessarily mean that you'll get osteoporosis. Does that make sense? So you can see, if you look at this curve, you've got 25-year-olds, 35-year-olds, 45-year-olds, 55, all the way up to 85, right? Now, you can see that at the age of 85, it's almost abnormal to be normal. Does that make sense? Okay, because the words we use, normal bone density, osteopenic bone density, and osteoporotic bone density, are not really, the word normal in that context is not really the way in which we use normal in everyday life. Does that make sense? So by saying someone's got normal bone density, you're not saying they've got normal bone density. You're just saying they're not osteopenic and they're not osteoporotic. Does that make sense? Okay, all right. So in the answer to the person who asked the question, I've got osteopenia, right? What should I do about it? First thing is, don't worry. Okay, that is the first thing. If you're osteopenic, there's loads of other people osteopenic too. Okay, you can see that at the age of 65, a majority of the people have either osteopenia or osteoporotic. Does that make sense? Right? So don't worry too much. So at the age of 50, being osteopenic is, or even osteoporotic, so being osteoporotic at the age of 50, it does put you up towards the upper end. But in fact, it would still mean that there are some people whose bone density is not that bad for someone of their age that will still be called osteoporotic. I hope that makes sense. All right, so that's the reason why this individual, although they were called osteoporotic, they didn't receive treatment, because when you added up their other risk factors, like whether or not they smoke, whether or not their mother had a fracture in their hip, and that so on and so forth, when their risk factors were added up, they didn't really have such a high risk, so they didn't receive treatment. Okay. The other thing to say is that this is an example of the population aged 35, 55 and 75. And these two lines, I don't suppose we've got a pointer, have we? Is that a pointer? Oh, there we are. So 35, 55, 75. Now, if you're below this line here, you're osteoporotic. Does that make sense? So if you're below this line, you're osteoporotic. And so you can see that even people who are osteoporotic don't necessarily fracture, because the ones that are purple are fractured. Okay? So the ones that are purple are fractured. And so you can see that you can still have osteoporosis and not fracture. You can still have osteoporosis and not fracture. And yet you can have osteopenia and fracture, and you can be normal and fracture. Okay? Fractures are common. The difference with having osteoporosis and fracturing is that we have treatments that can stop you fracturing again. Does that make sense? If you have absolutely normal bone density and you've had a fracture, it may be that the treatments can't reduce your risk of fracturing again. Okay? So in a way, if you've had a fracture and you've got osteoporosis, well, it means we can do something about it. Okay, so it might be good news that say you've got osteoporosis. Maybe I shouldn't put it that way. Okay. So then there was another question. It is more problematical in the morning to eat breakfast and to take my calcium D3 Forte tablets, as the instructions state not to take whole grains within 2 hours of taking the tablets. Is there any way to work around this? Okay, so I was sitting there listening to the dietitian tell you that you shouldn't take phytates, okay, phytates, which are forms of, actually I don't really know what they are, but anyway, they're chemicals within cereal, okay, and it was thought that the reason why Asian people eat more chapatis, and it's thought that the phytates within the chapatis would bind vitamin D and make them relatively bind vitamin D and calcium, calcium in particular, calcium in their diet and stop them absorbing it, okay? And so that's why some of these packets from the tablets that you receive actually say, you know, take your calcium vitamin D supplements without food, right? So I think Calcitude D3 Forte says avoid food, and some of the other ones, different brands, say, oh, it's okay to take the food. Okay, so there seems to be an apparent contradiction. Okay, so for the ones that advise to take without food, why do they do it? They do it because in theory, you're more likely to absorb the calcium, okay, if you don't take it with food, right? But when they did a nurses study, they did this nurses study, 9,000 nurses, and they compared what the difference was in calcium metabolism and fractures and all sorts of things between those people that had calcium in their diet from their milk and cheese and so on, and compared it with those people who took supplements. Okay? Now, in actual fact, they found they were pretty similar in terms of their fracture risk, etc., and their calcium metabolism, irrespective of whether or not you took supplements, which people tended to take away from food, or if they had high calcium in their diet. The only difference was that the people who took supplements had a very slight increase in kidney stones. Okay? And it was thought that you're protected from kidney stones if you take calcium in your diet because it binds the things like phytates and phosphates in your food. And so there is a sort of belief that if you have enough vitamin D and you take calcium in your diet, your body will absorb as much as it needs from the food. Does that make sense? So I tell people take calcium and vitamin D supplements with food, because I'm going on the basis of the nurses study with 9,000 people where they actually looked at this. All the other supplements, some of them say take with food, some of them say don't. And in the presence of confusion, I prefer to rely upon studies which have looked at this. Okay? So my advice to everyone is to take calcium vitamin D with food, and I would tell the person who asked this question to ignore the fact that the leaflet that they've got says don't take it with whole grain cereals. Okay? In theory, you might absorb less calcium, but in practice, we don't know if the little bit extra that you absorb really matters. Okay? And there's a little bit of data to suggest that maybe it's a bit safer if you don't absorb that much calcium. Okay? All right. So I hope that answers that one. There was a whole series of questions about calcium vitamin D. Okay? Could an injection of calcium cause a break in my thigh bone? I think not. Okay? And then it says, should my two daughters, aged 47 and 36, take calcium vitamin D as I take it for osteopenia? Now remember, osteopenia is not that uncommon. You shouldn't worry about it. Okay? You shouldn't worry about it. And should you encourage your daughters to take other things? Only if they enjoy them and they taste nice. Really, I don't think there's a huge amount of evidence of giving supplements to young people. As long as you have a balanced calcium-rich diet and are eating healthily, I think that's a good rule of thumb. Nothing to excess, nothing too little, don't cut anything out too much, don't take anything too excessively, okay? So, is it true that after 3 years treatment, calcium tablets, an injection annually and a good diet, that your bones are no longer osteoporotic? Okay, so this is a difficult thing. It will depend on an individual, and I can't say that you can say that people will, as a rule, definitely be better. For a start, you'd have to repeat the bone density scan to see if someone was no longer osteoporotic, and I tend not to recommend that people repeat their bone density scans too often. Someone may pull me up on that. Anyway, so then, are there problems with calcium intake and stomach acids? Okay, so if you've got a higher stomach acid, right, calcium probably is absorbed better. Okay, but remember I just told you we're not too certain quite whether or not the calcium effect has got to do with absorption or whether it's vitamin D level, so I wouldn't be too hung up about it. But this was one of the reasons why there is some evidence that if you're taking drugs like proton pump inhibitors or omeprazole, that you've got a slightly higher fracture risk. Okay, and we don't know why that is, but it is possible that it might interfere with calcium absorption. Okay, so when you ask, is it true or are there problems? There may be problems. Would I suggest that you do anything different to what you want to do? No. So are there any side effects of calcium on vasomotor disorders like Raynaud's? Not really. Not as far as I understand. Okay, so then we're going to move on to a set of questions about alendronic acid. Okay? So alendronic acid, the mainstay of treatment. Okay? Now, these questions, just going to run through them. Concerns about the side effects of alendronic acid, what can help them? How long has alendronic acid been in use? Is there any evidence of benefit? Is there an alternative to alendronic acid? As taking it half an hour before food and sitting up straight and don't take milk, etc., is presumably, upsetting. Is it true that alendronic acid, bone affected by alendronic acid deteriorates after 2 years? Does the calcium I take help with alendronic acid and help my diagnosis? Is there a time limit on alendronic acid? And is depression a side effect? So I'm going to answer specific components of this, but concerns about side effects of alendronate. Okay, so alendronic acid is generally well tolerated. There are 3 concerns. Okay, esophageal cancer. Okay, pretty frightening. Okay, if there is a link, there were 2 studies. One study showed a link, the other study showed there wasn't a link. Okay, so if there is a link, it's a link that occurs after 5 years. Okay, which is why the recommendations are moving towards taking it for 5 years. The second risk, atypical femoral fractures. So there's this idea that you make the bones too hard and too brittle, and then people develop fractures in the middle of their legs. Okay, now people are still concerned about that. Okay, and we've written a paper. Mark Edwards and myself wrote a paper on this. Now, it is very rare. People looked at there was a population study in Norway, I think, and they didn't really show a firm link. So people don't know. People don't really know if it causes it, but there is some suggestion that it might. But again, if you don't take it for more than 5 years, or if you tend to err towards a shorter period, then maybe it's not going to be that much of a problem. And then the last one is osteonecrosis of the jaw. So that's poor wound healing after dental extraction. Okay, so that's been estimated to be a very rare side effect. Okay, 1 in 10,000 to 100,000 patient years. And of the cases that have occurred, only 3% are due to osteoporosis. Most of them are due to other things, primarily cancer. Do I think that alendronic acid is safe? Yes, I do. Okay. Is it sensible to maybe take it for 5 years rather than 15 years? Probably. Okay. Do the other treatments for osteoporosis also have the same risks? Yes, they do. Right? Most of the other treatments, so Denastrimap, intravenous zoledronic acid, other forms of bisphosphonates, they all carry the same theoretical possible risk. Okay, I would give alendronic acid to my mother, I therefore don't really have any reluctance in recommending it. I do think it's safe. Then it says, how long has it been used? We're going to talk about that in a minute. This bit about does calcium help? It does. Calcium and vitamin D taken with alendronic acid is how it was used in the studies, and that's how it's been shown to work. Okay, and we actually know that there is quite a high proportion of vitamin D deficiency.
Excuse me, but I thought in my instructions for alendronic acid it said don't take calcium within 4 hours.
Yes, so you shouldn't take it with it, but being on it is fine. So for instance, alendronic acid, as you know, or should do, you take it first thing in the morning, empty stomach, large glass of water, and you mustn't eat or drink anything other than water for at least half an hour, and you must not lie back down. Some people will say, oh, it says I've got to stand up. Right? You don't have to stand up for half an hour. Right? You just mustn't lie down. Okay? I've read the instructions myself. When I read it, I thought, hey, it does mean you have to stand up, but really it doesn't. The idea is that just don't have to, just don't lie down for half an hour. Okay, then that's why I tell people to take calcium vitamin D with lunch and dinner, because I think it'll avoid if they take the hyaluronic acid in the morning. Is there a time limit to being on hyaluronic acid? No, but 5 years is a good number. Now let me just show you this. This is evidence performed in 1998, right? So 18 years ago, right? This is how long hyaluronic acid's been around, showing that 18 months worth of hyaluronic acid reduced your risk of hip fracture by 63% in this paper published in The Lancet. Okay, so hyaluronic acid does work, and it reduces your risk of fracture by 63% in that study. Now, this is a study that makes me again more confident about telling you about 5 years of treatment. In this study, patients took hyaluronic acid for 5 years, 0, 1, 2, 3, 4, and then at the 5th year, they either stopped it or they continued it. The ones that continued, their bone density stayed the same. It didn't go up like this, it just stayed the same. The ones that stopped, the bone density fell. Okay? So you'd have thought that losing bone density was a bad thing, but in actual fact, when you then look at them at 10 years, you discover that the rate of fracture was the same in the ones who stopped and the ones that continued. Okay, so that shows that the stuff hangs around and continues to protect you. Now it is possible, and they did show this, okay, that if you have very bad bone density and you are at very high risk of fracture, that this small reduction in your bone density could lead to an increased risk of fracture. Does that make sense? So for some people who had really quite bad bone density, the recommendation has been to remain on it for 10 years. The reason why that recommendation is there for 10 years, despite the concerns about over 5 years of treatment, a very small risk of esophageal cancer, okay, is because the evidence, the quality of the evidence about esophageal cancer is simply the observation that in the duration of the study that it was done, the two things went up at the same time. The use of alendronate went up, and the rate of esophageal cancer has been going up. The rate of esophageal cancer has been going up for the last 20 years. We don't know why. Okay? So just because someone has drawn and said these two things are going up together doesn't necessarily mean that one causes the other. In the studies looking at people who were given hyaluronic acid, they didn't have an increased rate of esophageal cancer. So that's why I'm relatively comfortable about that, and that's why if people have a very high risk of fracture, I wouldn't worry about giving them for another 5 years, over and above the first 5 years. But for most people can basically have a holiday off their bisphosphonates. So people talk about this bisphosphonate holiday. Right, I wonder if they're going to be sent anywhere nice. But anyway, so this idea about a bisphosphonate holiday, our recommendations, our local recommendations are that you consider being off it after 5 years for 3 to 5 years. Why do we say 3? The reason why we say 3 is because you can see by the 3rd year, the bone density is getting very close to where it was at the beginning. Okay? And that's why I say 3 to 5 years. So you can imagine that someone who had lots of fractures before they were put on treatment or was very high risk, then you'd err towards 3 years. And if, in fact, they've never fractured, right, you might not start it again, or you might just wait for 5 years. Okay? Hope that makes sense. Okay, so then we had some questions about Denastrimap. So Denastrimap is the injection under the skin, okay, every 6 months. And it says, how do doctors know that Denastrimap is having an effect on the bones? Okay, so that sort of invites the thing, well, why don't we repeat the bone density scan? Okay, so we could repeat the bone density scan, but generally speaking, we know that if we take you off the Denastrimap, your risk of fracture goes up. So we're probably going to tell you to continue it, even if your bone density is improved, at least initially. So if all you're going to do is leave people on the treatment, why waste the money on the bone density scan? Okay, so you can see the reason. Okay, I've got nothing against repeat bone density scans. It's only worth a few hours of radiation, background radiation, so it's a safe procedure. But it's all got to do with resources within the health economy. And then it says, do you stop taking Denastrimap injections after 5 years, like other medications? No, you don't. Why? Because Denastrimap doesn't work like the bisphosphonates. It doesn't work like alendronate. It's in you for 6 months and then it goes away. Okay? Whereas alendronic acid is in you for 60 years. Okay? So there's a marked difference in the way in which they work. Okay? So we generally tend not to tell people to come off it. Okay? We tell people to review the treatment at 3 years, because when we initially started recommending it, 3 years was all the data we had. Okay? But it should probably be reviewed at 3 years, but probably then continued. And then it says, are there any big side effects of taking Denastrimap? So the big side effects of taking Denastrimap are the same concerns that I said with the bisphosphonates, except for the esophageal cancer bit. It's the atypical femoral fracture, so that's a fracture in the mid-thigh that you're not expecting, and poor wound healing in the mouth. Okay? So is Denastrimap a good option for bone treatment? So the way in which it's placed is that if you can't tolerate the oral treatments, then people suggest that the NICE guidelines allow you to try Denastrimap. Now, we do have data on 8-year use and 10-year use of Denastrimap, okay? And basically it shows that it's still safe and that it works. So if I just show you this, people were osteoporotic. So the people who were better than osteoporotic at baseline was 11% when they started Denastrimap, and then 8 years, 82% of the individual's bone density was better than the osteoporotic threshold. I could explain this graph, but let's move on. We already. So then, at 10-year use, this is 2,300 patients who've been on it for 10 years, and 2,200 patients who were initially on placebo and then were on it for 7 years. Okay, so this is the bone density in individuals who've been on Denastrimap. Okay, now you can see that that the people that stayed on it for 10 years, their bone density on average went up by 21%, and you notice that it's continuing to go up. Remember, I showed you that graph. People on alendronic acid, right, Fosamax. Their bone density went up and then plateaued off and stayed the same after about 3 years, and then it plateaued off. Whereas this one, it just keeps going, okay? And it works both at the hip and the spine. And then for those individuals who remained off treatment for 3 years because they were a part of the trial and they had the placebo, and then after they had the trial, they then went on to the proper drug, their bone density went up as well. Okay, so these are the spine, the green ones are the hip. Okay? And this is the number of fractures after a number of years. So if you were on placebo for the year 0 to year 3, the number of fractures, I think this was in percent, went up. Whereas if you're on treatment, you didn't have any fractures. And then if you're in the 4th year, 5th year, the number of fractures you have is still less than placebo. Okay? So in terms of side effects, there have been 2 cases of atypical femoral fracture, so fractures in the mid-thigh. Only 2 cases, and that hasn't increased. And then in terms of osteonecrosis of the jaw, there have been 13 cases, okay, which is equivalent to 0.4 in 1,000 years. And there weren't any other concerns. In particular, there were concerns initially about infection being a possibility, because that was shown in the initial trial. And those concerns, although they're still on the drug information, they haven't really been shown to be a problem. So, questions about alternative medication. So we're close to the end, I think. So someone asked, I have breast cancer and recently diagnosed with osteoporosis. I had to stop my HRT. Are there any alternatives? So there are lots of alternatives. And really, in the context of breast cancer, I don't recommend HRT. Then someone says, how will I know if zoledronic acid infusion was successful? How can I be sure that there will be no side effects if I have a tooth removed? Okay, so you can't be absolutely certain that there won't be a side effect, but the side effect is rare. You can, for instance, stop the zoledronic acid, have some time off it. Okay, that makes some sort of sense, and maybe have your tooth extracted before it. But in actual fact, I told you those sorts of drugs hang around for ages. So whether or not you stop it or not may well not have an impact on your risk of having osteonecrosis of the jaw, which in any case is really rare. I stopped taking Risedronate after 10 years. Should I restart it? So if you've been on Risedronate for 10 years, our advice would be come off it if you've not had a fracture and you're not at high risk, okay? And then consider restarting it in the 3 to 5 years. For some individuals, so we have patients who've had multiple vertebral fractures, and the last time they had a vertebral fracture, they had a pneumonia and it almost killed them. So in those individuals, quite often they're on, they've got chronic obstructive airways disease and they've got really quite delicate lungs. You would simply say to them, it's far better that you remain on the treatment. Because all these risks are to be viewed in context. So how long should I take my bone medication? I think I've told you about that. 5 years generally, and if you're at high risk, 10 years, but for most people, after 5 years, they can stop for 3 to 5 years and then go back on it. And then are there any other pain relief available? So no, so bisphosphonate treatments have a variable effect, or these treatments have a variable effect or variable impact on pain. Okay, there's some evidence that teriparatide improves back pain. There's some evidence that intravenous zoledronic acid improves back pain. But and there's some evidence that teriparatide improves back pain. If I haven't said that already. I wouldn't think that a lot of them are really there. The bone protection ones are not really there for pain. So now there's a chance for people who are here to ask questions. If you stick your hand up, we'll have a roving microphone.
So stops the body from making the calcium. Is that why when you fracture a bone it won't heal?
Okay, so the question is, I mentioned that omeprazole might impair calcium absorption, and therefore that's why you might get impaired healing. So as far as I'm concerned, omeprazole might impair calcium absorption, but I don't actually, that's a mechanism that's been proposed, okay? I don't know if that's true, right? If someone needs omeprazole, I tell them to take it, yeah? Now, in terms of whether or not it impairs wound healing or fracture healing, I don't think that it is such a great factor. There are lots of reasons why people might not heal. So anti-inflammatories are supposed to stop people healing. Lots of other things are supposed to impair fracture healing. Sometimes it just happens. There used to be concern that the bisphosphonates would reduce fracture healing, but now we have a trial showing that after a hip fracture, if you have intravenous zoledronic acid after day 12, not only do you get up better, you live longer, and the fracture heals well. So we don't really have really strong evidence to suggest that it impairs fracture healing, and certainly not necessarily for omeprazole either. Does that answer your question? Yeah, okay, so there are reasons why people don't heal, and if we actually understood why they did in every case, but we don't recommend that people who have had a fracture stop their omeprazole. No. I'll go to you next.
Can I just clarify, you said calcium and vitamin D tablets. Do you have to use bisphosphonates with them, or can they be taken alone? Will they have an effect, basically? Calcium and vitamin D on their own, will they have an effect?
Okay, so there have been lots of studies trying to work out the interplay between calcium and vitamin D. Okay, there was a study where they gave vitamin D on its own and the fracture rate went up. Okay, So, and there have been studies where they gave calcium alone, okay, and they didn't improve fracture risk. The conclusion of a big meta-analysis by Tang, published in The Lancet, was that the higher dose of vitamin D and the higher dose of calcium that you took, the better it was for your bones. That's what they concluded. Now, there were concerns about calcium supplements increasing your risk of heart disease and heart attack. And there's one guy called Boland et al. In New Zealand who keeps basically publishing the BMJ every now and then. I don't think that's proven, okay? And lots of people don't think it's proven. But because of that, the recommendation has been that people, if they want to, can take calcium and vitamin D separately. So they can take calcium in their diet and vitamin D as a supplement, okay? Now that's the recommendation, the position taken by the National Osteoporosis Society, and it's the position that's generally recommended, okay? But it hasn't been proven by a study, okay? Say again? So AdCal D3 contains calcium and vitamin D together and is a combined preparation. And it's what we use as our standard treatment. Why do we use it? Because it's cheap. But there are lots of different forms of calcium and vitamin D. Some people tolerate some better than others. Say again? Okay, so I think the question is something like, can you take calcium on its own and vitamin D on its own? Yes, you can. Well, is it better to? I don't know. Right? All I can tell you is that studies looking at calcium on its own haven't really shown anything. Studies on vitamin D on its own haven't been conclusive. Most people believe that the evidence for improved fracture rate is with a combination of calcium and vitamin D. Generally, in all of those trials, they've been given together. And so, if you want to stick with evidence-based medicine, you would take them together. Okay, so the question is, do you take bisphosphonates with them or not? Okay, so there was a study in a French nursing home by Chapuis et al. Where they didn't give the bisphosphonate, they just gave the calcium and vitamin D. And that study, published in the New England Journal of Medicine, is the main reason why calcium and vitamin D is recommended. Okay, because it did show, for a relatively cheap treatment, that you had a reduction in hip fractures in a nursing home population. Whether or not you can extrapolate that to free-range elderly, as it's called, who are not in an institution, one can't be certain. But the general feeling from the meta-analysis has been that the higher level of vitamin D and higher level of calcium you take, the better it is for fracture risk. And the implication would be that you were to take them together, and you could take them separately, but I can't really inform that because no one's done that.
Oh, thank you. I've been taking andronic acid 2 to 3 months, and I've been having cramp in the night and when I go swimming. And do you think I should change to something else?
Okay, so the question really is, are those side effects in time relationship with the tablets?
Yes.
So the day after or something like that. Okay, so if you were to consider why would that happen, right? Bisphosphonates lower your blood level of calcium, okay? And people with low levels of calcium get more cramp. So if, for instance, you're taking this medication and it causes a low level of calcium in your bloodstream and you get the cramp, then the suggestion would be, why does that affect you rather than other people? Maybe you are relatively vitamin D deficient. Right? If you're relatively vitamin D deficient, your body won't absorb the amount of calcium that it needs to, and so consequently you will have a little lag in your response to the bisphosphonate, and you'll have a period of low calcium and you'll get cramp. So my theory would be, load yourself up with vitamin D, okay? So that would be a relatively high dose for, so what I would recommend is 3,200 units once a day for 12 weeks. Don't take it for more than 12 weeks, because otherwise you get toxic. But it takes time to replace vitamin D. And just if you simply take the AdCal D3, the amount that's in there is just for maintenance. And it doesn't actually make you replete and fill up your stores in your liver. So what you really ought to do is take a quick boost of higher doses, right, and then see if that makes you tolerate it better. Any other questions?
Yes, please. Yeah.
Oh, it's the lady with the mic and then... Sorry.
Hello, sorry. I'm a 57-year-old and I've been diagnosed with osteoporosis, mainly in my spine. And I noticed that you had up there saying that a 50-year-old was diagnosed with it and not taking any medication. Should I be taking the allogenic acid and the...
Okay, so it depends on your fracture risk, okay?
Right.
What you've got to remember is that bone density only explains 35% of the variability of your fracture risk. If you've got other risk factors, right, so you can be osteoporotic, and if you've never fractured at the age of 57, you wouldn't necessarily be told to take treatment.
I did fracture. I fractured a wrist, but it was a very bad form.
Okay, well, if you've had a low trauma fracture and you are osteoporotic on a bone density scan, guidelines, nice guidelines, say you should receive treatment. There was that question over there in the middle in the purple.
You mentioned kidney stones in connection with calcium. How much calcium is too much?
Okay, so if you get so look, with all these things, okay, you should, you know, osteoporosis is something that generally hopefully doesn't limit someone's life span. So if you are more prone to a particular risk, I would try to do things to avoid it. So if I had kidney stones, okay, I wouldn't make sure I was taking the full dose of calcium vitamin D. Okay, if I had a tendency to have kidney stones, because there is a small bit of evidence that there's a small increase, okay, then I would only maybe take half the dose of calcium vitamin D. So instead of 1 tablet, instead of 2 tablets a day, or AdCal D3, 1 tablet twice a day, I'd take 1.
So if you don't have kidney stones, is it okay to take the full dose of calcium?
Yes.
Right. Okay, thank you.
Okay, so I think we should draw a close. If you've got any more questions, please do come at the end. So well done, everyone, for lasting this long. Give yourselves a clap.